Hello everyone. So we are here to discuss cancer oral cavity. So this topic I am going to discuss with you in the form of a case where we'll take up a case and then we'll discuss the relevant point to complete the topic of oral cavity malignancy a slight in detail. So this is a 62-year-old man who is a labor worker and he has come up with a painless ulcer in the oral cavity since 5 months. Now, please clear it that painless ulcer could be a chronic inflammatory ulcer as well, not a necessary a malignant. But for sure, it is not going to be an acute inflammatory ulcer because an acute inflammation will be associated with pain. Yes. So the patient was apparently well 5 months back, after which he has noticed an ulcer in the left buccal cavity, which was insidious in onset and rapidly progressive in size from 2 by 2 centimeters to 6 centimeters now. Again, progressive increase is something pointing more towards an ulcer being a malignant one. Okay. Now, initially the ulcer was over the left buccal mucosa. Later on, it has grown beyond it to involve the upper and lower lip. So it is invasive, it is locally invasive. Again, a point going in favor of malignancy. Now, a very important point to be considered that it was initially painful and later on it has become painless. See, inflammatory ulcers will always remain to be painful ulcers. They will progress, and at the point of complete unhealed stage also they will present with pain. But a malignant ulcer can throughout be painless, or it can be painful earlier and later painless. Now, to be clear, with oral cavity malignancies, there is a very high proliferative rate in the earlier stages. Two important points to be remembered about oral cavity malignancies. The proliferation rate is maximum in the start, and secondly, the proliferation is maximum along the edge. So, whenever the ulcer will develop, since the proliferation at the start is at a very high rate, they will easily encroach upon the nerve endings and will cause pain. That's why these ulcers typically tend to be painful earlier and they become painless later. Now, it is not associated with loosening of teeth. See, further I am going to discuss the negative history. We take negative history in general in medicine for three reasons. First is to identify the cause of the disease. Second is to rule out the differential diagnosis. Third is to rule out complications. And in surgery, the fourth important point to take negative history is to rule out certain staging modalities associated with the disease as well, especially in oncology, surgical oncology. Here, loosening of teeth, in general, loosening of teeth will represent as involvement of alveolar processes of the teeth. And since this involvement will cause loosening of teeth will be considered as a locally invasive cancer. No history of bleeding or discharge. Generally, malignancies tend to bleed, but oral malignancies, they rarely bleed. The reason behind that is that in spite of being highly proliferative, having highly vascular structure, but rare to bleed because of a tense cellular mass surrounding the blood vessels. So the blood vessels are surrounded by tense cellular mass, which will not allow the blood to easily pout out. There is no constitutive symptom in this case, such as headache, vomiting, nausea, some fever, malaise, weakness, nothing. So again, it is not pointing to any inflammatory infectious cause. There is no difficulty in chewing or swallowing or speech. Now see, one more important feature about oral cancer. Oral cancer has many special features. One oral cancer feature is it shows field cancerization. What is field cancerization? That in a specific area of the oral cavity, if the epithelium undergoes dysplastic changes because of any form of insult and forms a primary tumor. Similar primary or a secondary will develop along the way from the epithelium surrounding towards the outer aspect of oral cavity or inside. This is called field cancerization. That means, for example, if a patient has oral cancer, there is possibility that the patient has similar ulcers or similar cancerous lesions in the oropharynx posteriorly, in the laryngopharynx, or in near the upper end of esophagus as well. That's why, to rule out that, we are taking a history of difficulty of swallowing or speech. Then no history of trismus. Trismus is a painful restriction of mouth opening, and this painful restriction of mouth opening is just because of involvement of pterygoid muscles and retromolar trigone. Now, the pterygoid muscles are attached to the base of the skull, to the medial and lateral pterygoid plates. That's why again trismus is considered to be a advanced invasive carcinoma because it involves the base of skull. We will discuss that when we come to the staging of oral cavity. A very important point again, no history of loss of appetite or significant weight loss. Since the mass is highly proliferative, the blood supply to that area, yes, is going continuously, and so there is a very low rate of cell death in these cases. Oral cavity malignancies have least chances of necrosis, and since there is no central necrosis, the amount of TNF, that is tissue necrosis factor alpha and beta, these are not secreted. And we know that TNF alpha and beta are cachexians, they cause weight loss. And since here there is no TNF alpha and beta, patients with oral cancers rarely present with loss of appetite and significant weight loss. What is significant weight loss? Significant weight loss means a weight loss of more than 10% of the body weight over 6 months, and or more than 5% of weight loss in a month. That is called significant weight loss. Radiation exposure. Radiation is considered to be a risk factor for oral cancers. There can be two forms of radiations, either a low dose radiation exposure or a high dose radiation exposure. A low dose exposure is considered as mutagenic, it will cause mutations, whereas high dose, that is more than 2 centigrade of radiation exposures, are ablative, they cause ablation of the tumor, and that's why a history of low dose radiation is more significant towards a chance of malignancy, whereas high dose radiations don't give a chance of malignancy in the patient. Similarly, a high risk behavior such as multiple partners, IV drug abuse, this point out towards infection, that is human papilloma virus, especially its strain 16 is considered to be a high risk factor for oral cancer malignancies. No history suggestive of distant metastasis. Oral cancers tend to metastasize as a complication. You can consider that they tend to metastasize to lung, liver, bone, and brain, rarely brain. So the history which we are going to take from the patient is firstly dyspnea and jaundice, secondly bone pain, third is the liver metastasis. Now liver metastasis is very significant. Earlier sign to be developed is going to be loss of appetite, and later on, as the metastatic nodules increase in size, grow diffusely throughout the liver, that will cause jaundice, and if it involves brain, that will lead to seizures and sometimes even intractable seizures which cannot be treated with any drug. No anti-epileptic, no anti-seizure drug can heal the seizures. My patient is non-diabetic, non-hypertensive, has no chronic illness such as tuberculosis specifically. The reason of taking history of tuberculosis is in Indian setup. In India, tuberculosis has a very high incidence as well as prevalence, and such ulcers that we will further see grossly how they appear, such ulcers most of the time are similar to that which are seen in tuberculosis. That's why we are ruling out the history of exposure as well as constitutive symptoms associated with tuberculosis, such as evening pyrexia, significant weight loss, and cough. There is no history of medical surgical interventions, allergy or drug intake. Patient is non-vegetarian, bowel, bladder, sleep habits are normal. Then two important points furthermore: chewing tobacco for past 20 years. He's not keeping it in the mouth, he's spitting it out. Why this history is important? That when a patient makes a quid, a pouch of these tobacco contains in different forms, and he keeps into the gingivobuccal sulci. If he keeps it into the gingivobuccal sulci, the contact time of the nicotine with the mucosa will increase, and this increase in contact time has a higher risk of developing malignancies. If a patient is keeping the tobacco in the gingivobuccal sulcus for a longer time, the risk of developing malignancy is higher or is in the earlier age. And if he's spitting out, he has a risk of developing malignancy, but it will be slightly in a later age. Alcohol has no direct relation, but it actually enhances or helps the tobacco or even HPV to cause mutagenesis just by reducing the immunity of the mucosa. There is no significant history of head and neck malignancies in first degree relatives. Especially you have to take the history of those malignancies which are associated with KRAS and RB, that is retinoblastoma gene, Li-Fraumeni syndrome. Next is general examination. We have to examine it in a sitting posture, adequate daylight with informed consent. He is conscious oriented with time place person. Karnofsky performance status is 90%. BMI is 20.4. Well hydrated, febrile. Pulse rate is 86 beats per minute. Blood pressure is 126/72. Respiratory is 16. No pylorictus cyanosis edema clubbing. Now left upper cervical lymph nodes are palpable, but there is no generalized lymphadenopathy. What is generalized lymphadenopathy? If more than or equal to 2 non-contiguous group of lymph nodes are involved. I'll repeat, more than or equal to 2 non-contiguous group of lymph nodes are involved, it is called generalized lymphadenopathy. Here we have only the upper cervical lymph nodes which are palpable.